Welcome everybody to this evening's meeting of the African Regional Discussion Group for the International CML Foundation. Just a quick word of introduction about ICMLF before we get started. My name's Amanda Woolley. I am moderating this meeting on behalf of the foundation this evening. ICMLF as an organisation are a physician and researcher-based foundation with two key priorities, both working towards improved outcomes for CML patients around the world. Firstly, we're raising the bar of CML management through CML education, and that includes meetings like this. And over the last 15 years, the foundation has been working via preceptorships, meetings, symposia, and online, for example, with our online knowledge centre, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The other side of our work is harnessing the power of global research. Our ideal is to work towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have a Genomics Alliance, we have a TFR Alliance, and there was also a huge amount of work done around CML and COVID. There is a hepatitis B survey in preparation, and we're also looking at pregnancy in low and middle income countries, pediatric treatment in low and middle income countries, and much, much more to come. So that is a brief introduction to the CML Foundation for those who may be new to our discussions. This evening, I'm really pleased to have a fantastic expert panel coming to speak on two topics. First, we're going to be looking at TKI choice and sequencing in a world of increasing choices. And then following that, a discussion around challenges in hematopoietic stem cell transplantation. A word of introduction for our fantastic panel in a moment, but first I just want to go through a few logistics. So please leave your microphone switched off until you wish to speak. We really want to hear your questions. We very much want this to be a discussion amongst everybody who is participating here today. But while you're not speaking, if you can have your mic on mute, that really helps. It's great if people talking have some spaces to speak to. So if you are able to leave your camera on, that's really helpful for everybody. And it's nice to be able to see people. Throughout the presentation, feel free to put your questions into chat or to raise a hand so that we know a question is coming. I will invite you in to speak when we're having the discussion spaces. It's really useful to know that people have questions waiting so we can make sure that we've got time to get to everybody. At any point, if you've got a question about logistics or about using Zoom, I'd invite you to send a direct message to my colleague, Stephanie Bockwinkel. She is my colleague from the foundation and is available to help with any technical issues that you may have. And any interpretation questions, please direct those towards Laurence or Giselle, and they will be able to help you there. So for our first topic this evening, TKI choice and sequencing in a world of increasing choices, I'm really pleased that we will be hearing from Dr. Matilda Ongóndi from the Kenyatta National Hospital in Nairobi, Kenya. Dr. Matilda is an eminent hematologist in Kenya and a good friend of the foundation. She has been a tireless contributor to our CML COVID case collection. She's a past preceptor, having spent time with Professor Tim Hughes in Adelaide, and she's on the Foundation's African Steering Group and is a past presenter in these discussions. We found a nice routine in sharing World CML Day events in Kenya through her leadership with the Kenyan Society of Hematology and Oncology. Matilda, thank you so much for joining us today. In response to Matilda's cases, we'll be hearing from Professor Susanne Saussele, who's a giant in the CML field, only preceded by her reputation. It's an honor to have you with us here today, Susanne. Susanne is a long-term contributor to the Foundation's work as a speaker, a topic leader on the Knowledge Centre, and in providing advice about difficult and interesting cases through the case discussion website. This is her debut appearance at one of our regional discussions, but I hope it's the first of many opportunities to learn from you in this setting. Matilda, if you'd like to start getting your slides up, that would be great. Just to say that later we'll be hearing from Professor Bazuaye, Godwin, Nosakhare from Nigeria, and from Professor Naeem Chaudhri from Saudi Arabia, and I will introduce them in more detail later on. So if I just stop sharing there, and Matilda, if you are able to get your presentation
Can you see
up.
my screen?
Not yet, no.
Okay. On my end,
I
it
can
says...
see it.
Oh,
Okay.
right, great. That's just me then. Okay, thank you, Matilda.
So probably also hopefully also the others, not only me.
Yes.
Yes, you may just have to click on to seeing the screen if that hasn't come up automatically for you. But Matilda, please get us started on TKI choice and sequencing of treatment.
All right. Thank you very much. And it's an honor to be back at the African regional discussion groups to share experience from our region, and then also to be able to have this discussion with experts such as Professor Susanne, and just compare notes in terms of being able to offer care with what we have, and try and optimize the outcome of our patients. So what we'll do in this session is I'll just go through some of the unmet needs in the region and the challenges that we face. Just give also a brief overview about the program in Kenya, and then we'll quickly go to the 2 case presentations, and we look forward to having a vibrant discussion. So in Kenya, the program was started in 2002, and this is at one of private facilities, pretty much because of being able to, this was a facility where testing was possible in terms of coordinating that and ensuring that the medicines which are provided actually get to the patient, and through the previous GLIVEC International Patient Access Program, and now Max Access Solutions. And we have a volunteer clinic that runs every 2 weeks. But in 2021, there was, after an MOU with the Ministry of Health, decentralization to other centers. And at the moment, we have approximately just slightly over 1,700 active patients, with almost 15% of them being on second-line treatment. And majority of the patients actually are seen at their volunteer clinic that's held every 2 weeks. So when it comes to choice of treatment, you know, when you look at the guidelines, and recently we had a very good review by Professor Jabber and Kantajan, just looking at, you know, where are we currently as CML stands. And what we know is that a lot of these guidelines are influenced by what is available and accessible in the setting. For instance, when you look at initiating treatment and looking at the goal, are you looking at survival or are you looking at TFR in a younger population, and that influencing your choice of care of TKI? Cost of TKIs for us, the TKIs are through the access program. So by and large, for every entry patient, they are initially put on imatinib. And then what comorbidities do these patients have? And what's their risk category? Again, because of delayed presentations, what we find is that majority of our patients are high risk, because, you know, that also comes into play in terms of choosing frontline therapy. Is your patient high risk in terms of the various scores, or are they low risk? And when we look at the unmet needs in the region, and I'd speak mostly about Kenya, although it mirrors some of the areas where we've been in contact with colleagues, And there's an overlap between the unmet needs and the challenges. So testing is still a big challenge. Getting a good peripheral blood film reported, access to bone marrow, and very few centers do provide for the BCR-ABL testing. And most of this is out of pocket. So that influences in terms of patients being able to get this in time where there's clinical suspicion, and then also being able to access the centers where that is available. So, and these financial challenges, we see that playing into the caring aspect once they've been started on the TKI. We know the guidelines say you should monitor every 3 months, but that is difficult in our setup. And what we actually are recommending for most patients is at least to have a BCR-ABL test once a year, but even that is an uphill task. Mutation testing is equally challenging. And I think the interpretation is, there's someone who has their mic on, is also challenging, and very few patients, in fact, I would say you can literally count the patients who are able to do that. So when it comes to the challenges, again, diagnosis, a clinical suspicion of CML. So sometimes you find patients being managed for infections, but we've seen over time that there's increase in terms of early referrals, lack of lab support. I will not overemphasize that. And then sometimes unnecessary tests, and it'll be interesting to hear what is seen in the other regions, such that sometimes you have a patient who has CML, they have a massive splenomegaly, but they also come with them at CT abdomen pelvis that's been done. And that involves, financial expenses, which is not really necessary. Delayed presentation, and this is either the patient seeking care or even just their transition through the various referral systems. Monitoring, as I mentioned earlier, compliance is a great challenge, especially with the young people. And then we are increasingly seeing patients who are failing their first-line TKI, and the challenges then in terms of sequencing and being able to choose the appropriate second-line treatment. And I'll just present a case. The cases that I'll present would be, I would say, a bit extreme, but I thought I would put them here because sometimes there are things we don't maybe routinely think about, but something that we see in our patients. So a young patient, 24-year-old, majority of the patients in our region are young. From most of the studies which have been done, our median age is between 40 and 45. And I saw a similar study which was done in Rwanda that put their median age at 30, in the 30s. So young population compared to maybe what is seen in the West. And for this 24-year-old, he presented with a 3-month history of left upper quadrant discomfort. He had unintentional weight loss, had occasional headaches and fever, had no comorbidities. And on exam, the main thing was that he had a massive splenomegaly, 20 centimeters below the costal margin, and also did have a hepatomegaly. He didn't have any lymphadenopathy. So of note is that his initial blood count showed an anemia of 10.3, a marked leukocytosis of 333, and this is usually the typical presentation of our patients, and his platelet count was normal. He did have a PBF that showed a full maturation spectrum in terms of the marked leukocytosis, and blasts at 3%. The bone marrow did show that he had a chronic phase. He was in chronic phase. And for our setup, we do actually recommend doing a bone marrow so that and especially since we're not able to do the monitoring every 3 months, so that you're able to appropriately place the patients, although more than 80% of our patients do present in chronic phase, but you do have a few who will present in accelerated or the high risk and blast crisis. His BCR-ABL was 34.7. He had a normal ALT, and I'll we'll see why that is important in this case. And as I mentioned earlier, you see, for this patient, he also did have a CT abdomen pelvis, and we question the utility of that unless you're looking for something specific. So he had a BCR-ABL positive chronic phase CML and with a high-risk UTOS score and SOCAL score. So we did discuss the diagnosis with his parents and the patient. They were all very anxious, started cytoreduction with hydroxyurea and allopurinol and had him registered to the program. Now, just 3 weeks into treatment, he had a febrile illness, was having fevers up to 40. And as you can see, his white count did start coming down and to 67, but so did his hemoglobin was at 9.14 and his platelets were 128. At this time, he also did have an AKI, and his ALT from a normal baseline shot up to 260. Of note, he had also been taking a bit of paracetamol or acetaminophen due to the headaches. We did various tests to look for infection, but all that was negative. And during this admission, we did hold his TKI, stopped the paracetamol and hydrated him and did give him a top-up transfusion. So his ALT did come down, and we reattempted reinitiating the imatinib. As you recall earlier, I mentioned for the program, the entry TKI is imatinib upfront. And you can see his white count did come down, but we're having challenges with his ALT. We routinely, we do, in terms of serology testing, HIV, hepatitis B surface antigen, and HCV antibodies. So, but for this patient, we had to recheck the hepatitis B surface antigen, which was still negative, and did a core antibody, which was also negative. And you can see whenever we stopped his, held his TKI, that his ALT did come down. The other interesting thing is that if we look over to the symptom section, is that he did have, as expected in terms of the side effect profile, ankle swelling and myalgia and arthralgia, but these were debilitating. He's a university student. And so given all this together with the high ALT, which we concluded was a drug-induced hepatitis, we did switch him to dasatinib. So we started him on 100 milligrams of dasatinib, and you will note his, in terms of the splenomegaly, he did have resolution of that. So if you're to look at his clinical response, he was responding, and his white count was going down and actually normalized, but he was having challenges in terms of toxicities. So he did have a drug change because of toxicity. In this case, drug-induced hepatitis and then disabling arthralgia. So when we changed him over to dasatinib, his ALT remained normal, but his platelets started trending downwards. And we did reduce his dose from 100 to 50 milligrams at the time. He was doing well. And once he had taken, his parents were really keen on monitoring. So this is not the typical patient. Most times patients struggle to do the monitoring. And you can see his BCR-ABL after 3 months was 25%, so still high. And he was now beginning to have significant cytopenias, mostly his platelets. And he got down to a nadir of 75, so not too bad. And at this point, we did evaluate him. One of the interesting things that we see with a few select patients, this won't apply to all the patients, but we do have a few select patients, surprisingly young patients, who actually have bone marrow suppression from the TKI. So that's
Matilda,
something interesting.
Yeah.
Yes.
I wonder if this is a good time to bring Susanne in, and I want to make sure that we've got time to go through both of your cases and have some discussion further on as well. Susanne, are there any comments that you're thinking of so far in what Matilda has presented?
Yeah, thank you. That's a very interesting case. So I have one question. I didn't get the point why you reduced the dasatinib 100 milligrams to 50. If you go back in your slides, I didn't get the point. So there was some side effects, or what was it exactly? Here between
Thank you.
March and
Yes.
May, yes?
Yes. So I think I have some numbers, or maybe I didn't put it appropriately. So that was here. His nadir count had gone down to 75. So that should actually have been here. So because of the thrombocytopenia that he was having. And the question probably would be, was that too early, a reduction? What are your thoughts on that?
Yes, actually, my experience is with the patients who have such a big spleen in the beginning and such a big amount of leukocytes, you have in most cases you have these problems with the thrombocytopenia, and he had also a very high thrombocyte count at the beginning. Yes, and these are the patients. I think they have the BCR-ABL also in the platelets, so. And they are a little behind in response somehow, and this is why it goes so down. Yeah, but it's difficult to manage with the thrombocytopenia. What I do is that I try to, to accept more reduction. This is you said it's 72,000, so I go down to 30,000 or so in this setting. So if it's probably a problem in your country, because I can see the patients every week. If I say you have to come in a week, he's coming in a week. So I think you can have a little bit. It's probably not so common in your setting. Yes, it's more difficult to see the patients every week.
Yes.
Yeah, so that's a problem then to really go down. What I know from colleagues from France, for sure, this is not. But what I do in some patients is that I give some cortisone, yeah, and then the platelet count is going a little bit higher, and so you can. So there's no need for this disruption of therapy or reduction, because I think in this case, it's no wonder that he's still on 25% BCR-ABL in June, because he has so many therapy interruptions and dose reductions that he's far behind his dosage he should have had at this time point. So I'm quite sure that he has no mutation. Yeah. Yeah.
Matilda, Naeem has a question. There's also a question in the chat, but Naeem, do you want to quickly come in with your
just
question?
one comment to Matilda, or question. Did you, when the platelet drops, if the patient is tolerating the TKI very well and there seems to be a response, did you try thrombomimetic agents like alpromobag or something to increase the count and still be able to push in some sort of half the dose or something? That would be helpful, because sometimes in the beginning you have to support them with these agents to get the medication in as well as assess the response.
Yes, that's a very good question. Thank you very much. In this case, we didn't try the thrombopoietin agonist, and I'm curious to know from Professor Susanne what your take is with regard to this in the early phase, and what would be your threshold for starting the thrombopoietin agonist, if it's available.
Actually, we are not able to prescribe the agonists. It's out of the prescription. Yeah, so I can't do it. The patient should buy on. Yeah, it's not common. Yeah, so I'm not able to do. Yeah, I know that some colleagues try it sometimes and it works. However, because it's so complicated in Germany to get the drug for the patients, I would more go for cortisone therapy. This was to raise the thrombocyte count. This was also successful in several cases in my ambulance.
And what would your comment be with regard to the concern about the thrombopoietin agonist stimulating or causing more clonal selection of adverse cells and maybe increasing the chance of transforming?
Yeah, there's no data. That's absolutely probably critical. Yeah, if you have the agonist introduced in the setting that the megakaryocytes are probably beta-ABL positive, so you don't know what's happening. So I only would do it if the beta-ABL ratio is lower than 25%. I think then you can go for that. Yeah. There's no data, no systemic data on that.
I can see that Professor Malhotra, you have your hand up. I'm keen that we also get to hear Matilda's second case. So maybe if you could come in, Professor Malhotra, with your comment, and Matilda, get ready to present your second case. That would be wonderful.
So I just wanted to respond to Professor Matilda's question. We have, fortunately, in India, both the parenteral as well as the oral thrombopoiesis stimulating agent available. And we normally don't reduce the TKI dose or do anything till the platelets counts go below 50,000. And then usually once you lower the dose of the TKI, they slowly settle down. And of course, there are concerns about using both GCSF as well as thrombopoiesis stimulating agents to stimulate and push the patients towards blast crisis. To be use it carefully and use it only as the last resort when we just cannot push in any TKI, and that is proving detrimental to the patient. Thank you.
Thank you. Thank you
right.
for that. Matilda, go ahead with your second case, and then we'll have a little bit more time for questions before we move on to our second topic.
All right. Okay. Wonderful. So I think for this first case, in summary, we've looked at the symptoms in terms of the side effect profile, lab monitoring, and the good nuggets which have been mentioned in terms of monitoring the platelets, just allowing them to be low, having a threshold of 50 before we switch, so that we try and optimize the TKI before we change to the second option. So the second case is that of a 40-year-old female, again presented with left upper quadrant swelling. And this case was a bit different because this patient had generalized lymphadenopathy that was bulky with associated weight loss. Most of her nodes, like in the cervical region, were maximum dimension of about 10 by 6 centimeters. So multiple huge nodes. And in addition to that, a massive spleen all the way to the pelvis, and a hepatomegaly 6 centimeters below the costal margin. Her preliminary blood count was showed an anemia of 7.2, marked leukocytosis of 300. Again, a picture in keeping with CML, which was confirmed on bone marrow. And for this case, the interesting thing is her initial BCR-ABL was reported as 1.390, but of note is that there was suboptimal controls, which is an important thing in our setup, where samples have to be sent off. And we actually had to have a repeat testing, which did confirm that her levels were more than 55%. And so she was a high risk, BCR-ABL positive, chronic phase CML. We started on cytoreduction. She was not able to do lymph node biopsy, which was what we had recommended at the beginning, and she seemed to do well after initiation of the TKI with the imatinib. Her counts did go down. She did have resolution of her lymphadenopathy, and as well as the hepatosplenomegaly, which was quite good for her. She was able to get around and had good energy levels. However, this was short-lived because in just a few months later, she started having joint pains. And then this was associated with a progressive leukocytosis. And this was worrisome because then we're concerned that she may be not responding to the imatinib. Remember earlier on, we said this patient had massive bulky nodes, which is not really a typical presentation upfront in chronic phase CML. So we're concerned that she's transforming maybe to accelerated or blast phase. However, we had delays in terms of doing a bone marrow. And later on, she was actually admitted because of severe anemia. So her HB dropped from 11.6. At the point of admission, it had gone all the way to 5. A bone marrow, which was later done, then confirmed that she had blast. So she had now frank transformation to blast crisis. At the onset, we didn't have, remember, we didn't have a lymph node biopsy, we didn't have a trephine biopsy, and you wonder whether maybe with just an aspirate, there's something that we missed at the point. However, she had that good response. Because of this, we did give her chemotherapy because she had bulky nodes and was having obstructive symptoms from the massive cervical lymphadenopathy. And later on, when we got more information, she did have a biphenotypic acute leukemia. However, the patient declined treatment and requested to be discharged. So Professor Susanne, for this case, I don't know what your thoughts are. She had bulky lymph nodes. What's your recommendation in terms of doing a lymph node biopsy, maybe a trephine biopsy at that front? We're not able to do, the 3-month BCR-able testing due to cost, even the initial lymph node biopsy. And then for us, something that's very real in our setup is just the social cultural determinants of health. Like she requested to be discharged, but we felt she wanted to go and pursue traditional medicine or alternative medicine. Yeah.
Yeah, absolutely. I think it could be a extramedullary disease at the beginning, and therefore this is a definition of blast crisis. So usually these blast crises frontline respond very well to TKI. So this could very much be a blast crisis from the beginning. And so the response is not surprising then, but it's not long lasting. And therefore the recommendation is at least in our country, then to start with the TKI, add not chemotherapy if necessary. But in this case, it's mostly like that you don't need an additional chemotherapy, that TKI alone is enough, and then proceed to bone marrow transplantation. However, I'm not sure, would you have changed anything in your treatment if you have known that there is something in the lymph node?
Mm-hmm. Yeah, that's an interesting question because we have actually a similar patient. And when we had an MDT discussion, we opted to monitor the patient closely and see if we can encourage them to do a BCR-able at least maybe every 6 months so that we're able to pick up loss of molecular response earlier. The only difference would be maybe patients who have, like we've had a few patients, but those ones have failed treatment and then had a blast crisis to AML. And for those ones, we've been using ponatinib and azacitidine. Some have had a good response. I would say on average 6 to 7 months is what I've seen before because transplant is not an option for the patients.
I think Naeem, you have your hand up. Would you like to come in? And also Professor Bazuaye, if another member of our panel, if you want to jump in and make a comment, please
Yeah,
do
my
so.
question was, Matilda, did you do a B-cell kinase domain mutation when the patient failed first time, or
Yeah, so that's a good question. In this case, no. As I mentioned, that's part of the challenges, the testing, and which is majority, I would say on average, 60 to 70% of our patients struggle with doing the monitoring. And most of them, we have to really talk to them when they're having signs of clinical or hematological failure, that to do the testing. So because most of it is out of pocket and not covered by insurance.
so if this patient had agreed for treatment, would you have taken this patient to transplant? You have the facility to.
I think in this case, that's a good question. Because I agree with Professor Susanne, most likely she was blessed at the beginning. So that would have been a discussion. However, upfront, given the reality in terms of finances, what I would have done is optimized then her TKI. So changed her to ponatinib to give her sort of the best option, because also should not have been able to do the TKI mutation testing, unfortunately, to help us appropriately select the TKI. So that's another challenge. I don't know if Professor Susanne, you want to speak to that, because we do a lot of blind sequencing of of the TKIs, not because we want, but because of the challenge of mutation testing. When they're in blast crisis, it's obvious, and we'll put them on ponatinib, but then also we have just a few slots for that. I don't know what your comment on in terms of the sequencing in absence of mutation testing.
Yeah, that's difficult to answer actually. Yeah, because if you, for sure it's ponatinib, then the next step, I would agree to that. However, the problem is then if they do not respond, that they probably can have a T315I. There should be that they have a compound mutations or so, and then it's difficult to have a next one. If I'm not sure if you have then afterwards something you can do. However, I think, you know, you're not the only country, so I think that we should work on the politics, that you are able to get better drugs, and what can we do from Europe? This is really an important question. If you say that everyone gets a CAT scan, you know, at least in our country, a CAT scan is at least 3 times more expensive than do a BCR-able testing. So I think you should more insist on your government, yeah, and make discussions with them, yeah, yeah.
Yeah, one more thing, I think if the patient remains in the chronic phase, it's sometimes safer to do sequencing without going to ponatinib, but somebody who goes into a blast crisis, then it is hard to do sequencing because the risk of T315 is higher when they transform.
That's
But
true.
if the patient had remained in CP, I think even without the mutations, you could take a risk of going to a second line.
Actually,
There's a
can
hand
you do,
up.
can you do cytogenetics?
No, it's
No,
so that's send out, which means it's dependent on the patient being able to do that. Yeah. And I think just to clarify, it's not all the patients who will get the CAT scans, but we see, and then it's covered by insurance. So you find sometimes by the time they are being referred, but you raise a good point. There's a hand up, Amanda.
Yes, I'd love to. I'd love to bring in some questions. So I'll invite Zoom user, which I'm guessing is not your name, to come and speak, but also draw your attention. There's a question in the chat around the risk of developing TKI, developing hepatotoxicity with TKIs. So if the panel want to respond to that, but the individual with your hand up, please come in. And,
okay, hello, I'm Dr. Hamisa from Tanzania.
Hi.
Thank you, Matilda. I have a comment for this patient's second case. I used to have a similar cases, which most of the time, it seems to be blast crisis from the beginning. But also I see there is a mandatory of doing biopsy, because sometimes there is presentation of, I got 2 patients with first diagnosis of CML and lymphoma. So sometimes the patient presents with lymphadenopathy. At diagnosis, we diagnose to be the CML, but when you do biopsy and we found out it is also lymphoma for that particular patient. So I see there is this need of doing a biopsy for this particular patient, because I have 2 cases for similar presentation. That is just my addition on the importance of doing biopsy from the beginning.
Can I ask you, did they have an indolent lymphoma like CLL, or?
No, it was a non-Hodgkin lymphoma.
Okay, an indolent, not high malignant one.
Yeah.
Okay.
Mhm.
It's interesting.
That's
So I had also
interesting.
one, but it's not so common actually, at
Yeah.
least in our country.
Yeah, but my country,
Okay.
it happens 2 cases with a similar presentation.
Yeah, very good point, and underlines that you need histology. Yeah.
That's interesting, Hamisa. Thank you for sharing that. The other case which we had actually was initially reported as lymphoma, but when the histology was reviewed at a different laboratory, they actually found it was what were being called the lymphocytes were actually more of atypical megas. So probably for me, what that case reminded me is also just really having a good pathologist look, and also second opinions, maybe multiple pathologists, so that you have a final review. Because for this patient, he was labeled as Hodgkin's and CML, but when we did the review of the histology, it was the extramedullary blast presentation. Yeah. Bazuaye has his hand up.
Oh,
You're
Bazuaye,
you're muted.
cannot hear you.
Can you hear me?
Yeah.
Yes, we can now.
Better. So I will say that I actually sympathize with Matilda, because obviously these are the problems in developing centers. Also, there's also need, I don't know whether you have general surgeons, there's need to actually have done a lymph node biopsy for this patient as soon as lymphadenopathy was observed, to see what was in the lymph nodes. Secondly, also too, I wanted to be able to estimate the burden. How many of your patients actually transform to blast phase, and what do you do with them? Do you have an estimate of what, because I know the burden is that there's no insurance, people pay from their pockets. So the question is, how many of your patients actually go to blastic phase, and what do you do?
Thank you very much for that question. I was going to rope in one of my seniors who I saw was in the meeting, that is Professor Abinya, who's a mentor and teacher, and actually the pioneers in terms of setting up CML care in Kenya. So actually, from studies which have been done in our patient population, the blast presentation about 1.5 to 2% in terms of the total patient population. In terms of what is done for the patients in absence of ready referral for transplant, the main thing has been to change them to ponatinib, increasingly with more access to azacitidine, and this is backed up by the PONAZA trial. We've been actually starting patients on azacitidine with ponatinib. And we've actually seen a few of the patients who've done well with that. So that's what we've been doing for now, given the absence of this accessibility to transplant.
That's great. There's one more question in the chat, which I will go to, and then we'll need to move on for time to our next topic. So Ahlam has put in the chat, what is the role of using steroids in TKI-treated patients that develop thrombocytopenia? For any of our panel today, expert panel today, please, if you've got a comment on that. Susanne?
Yeah, actually, I used it in some patients and it worked very well. So I think the background there is that it's a little bit also immune component, like in ITPs, in immune thrombocytopenia, that it works. Yeah, so it's a try, and as I mentioned, in some patients you can really have a success, so that there's no need to reduce the TKI.
Great. Okay. Any other comments from the panel?
Yeah, I have not used steroids as such in thrombocytopenia, but I've used eltrombopag, a small dose, and I try to reduce the dose of the TKI to some extent, a little bit, not too much. As long as the platelets are above 50,000, I feel safe to continue at a lower dose of TKI with some eltrombopag support.
I'm also curious about the experience of the colleagues from other countries with regard to cytopenias with the TKI, because that's something that we surprisingly see in younger patients. You'd think it's maybe the older patients, but young patients who you're really struggling, you do a bone marrow, and you find it's just hypocellular marrow, no blasts. And for the few who are able to do the BCR testing, you find that they are well controlled for their disease, or at least approaching a major molecular response.
Yeah. Well, if participants have comments on that, it would be really interesting to see. Please do put those in the chat, and we can pick those up. But for now, I will say thank you so much, Matilda, for bringing those two cases and for stimulating this fascinating discussion, and also Susanne for your response to that. And we will move on to our second topic now. Professor Bazuaye, if I could ask you to start loading up your slides and getting those ready, and I will just mention a few words of introduction for our next two panelists who will be leading our conversation on challenges in hematopoietic stem cell transplantation.